Okay, having looked at the humerus, the radius and the ulna, we can now move down to the elbow joint and the radioulnar articulations. The elbow joint is not a simple joint, it's a complex joint, being made up of the humerus articulating with the ulna, forming on the medial side, the ulnohumeral joint, and the radius articulating with the humerus, forming the radiohumeral joint. However, it behaves like a fairly simple structure in so much that it is a typical synovial hinge joint, allowing uniaxial movement and being reinforced by a strong set of collateral ligaments. There's a significant point to note here. When we look at the line of the humerus and the radius and the ulna, then they don't lie perfectly straight. There is a physiological valgus, which is known as the carrying angle. The humerus lies, if the humerus lies vertically, the radius and ulna, when sitting in the anatomical starting position, will lie at an angle of around 10 to 15 degrees in males and 20 to 25 degrees in females. This is hypothesized to be either a clearance angle, whereby when we swing our limbs beside our hips in order to move, in order to walk, we don't catch our hands on our hips themselves. Although some individuals hypothesize that it's actually a remnant of when we were quadrupedal, and this had the effect of bringing our hands underneath our body, so making our gait much more efficient. The articular surfaces of the elbow joint can be looked at all three bones should be considered. At the lower end of the humerus, we have the trochlea here, which is a pulley-shaped structure, and next to that, on the lateral side, we have this ball known as the capitulum. The trochlea and the capitulum are apparent anteriorly. The trochlea extends posteriorly. The capitulum does not. The capitulum finishes here inferiorly, but the trochlea does extend posteriorly. Now, the trochlea will articulate with the trochlear notch on the ulna. And the trochlear notch is reciprocally shaped to that pulley-shaped structure at the lower end of the humerus, and is formed by the olecranon process at the top and the coronoid process at the bottom. This articulation makes the elbow joint inherently very stable. It's the actual articular surfaces fit very well. It's very congruent, and it's this hook gripping onto the trochlea that creates much of the stability of the elbow joint itself. The radius, on the other hand, articulates with the capitulum, and it's the head of the radius that articulates with the capitulum. Specifically, it's the superior surface of the head of the radius, which is biconcave. So this is like a small ball, and this is like a small socket. And the two components, the radius and the ulna, that articulate with the humerus, form this typical synovial hinge joint. All bony components are covered in a layer of hyaline cartilage. It's a typical synovial joint. It has a fairly extensive fibrous capsule, and the fibrous capsule encloses not only the elbow joint, but it extends down to enclose the articulation between the top end of the radius and the top end of the ulna, the superior radioulnar joint. Superiorly, it attaches to above the olecranon, the radial and the coronoid fossae, and extends down inferiorly to blend with the annular ligament, which is the ligament of the superior radioulnar joint, which it then goes on to extend down to the neck of the radius. So over here we can see the radius. There's the capsule coming down here, blending with the annular ligament, eventually attaching down here onto the neck of the radius itself. Medially and laterally is where the capsule is strongest, and it's reinforced at this site by the medial collateral ligaments of the elbow and the lateral collateral ligament, or the radial and ulnar collateral ligaments. The synovial membrane does the same as any other synovial membrane. It lines the capsule and it attaches to the edges of the hyaline cartilage. But because the elbow joint has such an extensive capsule, the synovial membrane, not only does it line the inner surface of the capsule, but it then comes back down and covers any intra-articular bones. It actually comes down and covers the radial, olecranon and coronoid fossae. It goes on to blend with the annular ligament as well, so it's a fairly extensive synovial membrane. There are fat pads also within the fossae, separating the synovial membrane from the fossae themselves, and these are there partly to protect the bony components in extension. However, this anatomical arrangement, the fact that the synovial membrane and these fat pads sit in the fossa, makes them prone to impingement. And hyperextension injuries, in particular of the elbow, it's not uncommon to develop an impingement of the synovial membrane and the associated fat pad here in the olecranon fossa. It is a typical hinge joint, so therefore it has a strong set of collateral ligaments. On the lateral side, we have the radial or the lateral collateral ligament, which arises from the lateral epicondyle. It extends down as a small triangular structure that blends into the annular ligament of the superior radioulnar joint. Its function is to prevent adduction of the forearm and is tightest when it's in extension. The medial collateral ligament, or the ulnar collateral ligament, is slightly more complex. It is a series of bands, again, that the proximal attachments that appear on the medial epicondyle. It has a posterior band here that goes to the olecranon process, an anterior band here that goes to the coronoid process. There is a transverse or an oblique band that links the distal attachments of these two ligaments, and it holds these two ligaments tight into the olecranon. Some authors will describe a fourth band that goes from the epicondyle to blend to onto the deep surface of this oblique band, or the transverse band itself. It's by far the stronger of the two ligaments, and its function is to prevent abduction, abduction of the forearm. When looking at the surface markings of the elbow joint, it's the epicondyles that are the important components here, the identifying markers. What we do is we palpate the medial epicondyle and we palpate the lateral epicondyle. And it can be drawn, if we take the medial epicondyle, move down 2 centimeters, lateral epicondyle, move down 1 centimeter, and draw a line horizontally across. That would give us the surface marking of our elbow joint. The collateral ligaments can be palpated, crossing the joint medially here and crossing the joint laterally, and they can be stressed by forcing the forearm into abduction, abduction, or adduction. The joint itself is a very stable joint. The primary stabilizing factor is the articular surfaces. They're congruent, and there is a good size ratio between them, but the collateral ligaments also play a significant role in stabilizing the elbow joint itself. The muscles, to a certain degree, provide a degree of stability, and the elbow joint itself can be seen to be maximally stable when it's flexed approximately 90 degrees as a result of maximum bony contact and muscle activation. There is an area on the anterior surface of the elbow known as the cubital fossa, and this is comparable to the popliteal fossa down at the knee. It's a useful area to identify because this is where we can identify key veins, we can palpate the median nerve, we can identify the brachial artery and components of the radial artery. It's a body space that is important for identification of these neurovascular structures. Injuries of the elbow are often associated with fractures. Here we've got a number of x-rays here. We can see here a dislocation of the elbow, which is quite uncommon in adults. A dislocation in isolation is uncommon, but not unheard of. Dislocations often occur in association with various fractures, and here on this lower x-ray we can see a fracture of the olecranon process extending down here into the coronoid. Up here we've got a supracondylar fracture, and it's the bony architecture that predisposes us to these types of injuries. The collateral ligaments may get injured, but those sorts of injuries are less common. Moving on to the superior radioulnar joint. The superior and inferior radioulnar joints are both classified as synovial pivot joints. In other words, they permit the movements of rotation about the longitudinal axis of the bone. The articular surfaces of the superior radioulnar joints include the circumference of the head of the radius, as can be seen here, and that articulates with the radial notch on the ulna. These two components are covered in hyaline cartilage, and there is a ligament that attaches from the anterior border of that radial notch. It comes all the way around the head of the radius to attach onto the posterior border of that radial notch. This is known as the annular ligament, and the annular ligament, complete with the radial notch, forms this osteofibrous ring into which the head of the radius slots. The inner surface of the annular ligament is covered with fibrocartilage, is lined with fibrocartilage to allow smooth, friction-free movement of the radius during rotation. It shares a common joint cavity with the elbow, so therefore the capsule of the superior radioulnar joint is continuous with that of the elbow joint, and again it's lined with synovial membrane, just like any other synovial joint. Stability is offered predominantly via the annular ligament. However, there is a small structure down here called the quadrate ligament, which passes from the neck of the radius to just below the radial notch. That holds the head of the radius, the head and neck of the radius, in contact with the ulna. There is a structure that runs down between the radius and the ulna, known as the interosseous membrane, which is also a significant stabilizer of both radioulnar joints. When we look down at the lower end, we have the inferior radioulnar joint. This is far less stable than the superior radioulnar joint, and it is the articulation between the head of the ulna down here and the ulnar notch on the lower end of the radius. Again, bony components are covered in hyaline cartilage. There is a loose capsule that extends all the way around the articular surfaces, and again it's lined by synovial membrane. The joint itself is stabilized by anterior and posterior thickenings in the capsule, and again the interosseous membrane. However, there is a structure down here known as the fibrocartilaginous articular disc that goes from the lower end of the ulnar notch here. It goes across under the head of the ulna to attach to the styloid process. The disc here, the articular disc, actually keeps the ulna separate from the carpal bones. So over here we can see the head of the ulna coming down here. Here are the carpal bones that form the wrist joint. The disc itself keeps the ulna and the carpal bones separate. So the ulna itself doesn't actually form part of the wrist joint at all. This is the interosseous membrane. So here we can see the ulna, here we can see the radius. And passing from the interosseous border of the radius across the interosseous border of the ulna, we have this fibrous structure, this fibrous sheet, whose fibers pass obliquely downwards and medially. The only exception to that is the oblique cord at the top end, whose fibers pass downwards and laterally to prevent downward displacement of the radius. The function of the interosseous membrane in the forearm is to stabilize the two bones. It unites the two bones and holds them fairly solidly together. It limits movement, so it gets taut in the movements of supination and pronation. And it allows, most significantly, it allows the transmission of forces from the large lower end of the radius to the larger upper end of the ulna. The direction of fibers are such that when we load up the hand, load goes through the lower end of the radius gets shunted out, and because of the orientation of the fibers, the force gets transmitted up the radius, through the fibers, into the ulna, so it gets transmitted across the upper end of the ulna, which is the larger of the two components up there. It further compartmentalizes the forearm into anterior and posterior compartments, and openings at the top and at the bottom allow for the passage of blood vessels through between anterior and posterior compartments. It also plays a significant role in increasing the surface area for attachments of the muscles of the forearm. To identify the radioulnar joints, the easiest way to identify them is just to palpate them directly beneath the skin. All three articulations allow rotation of the forearm. When the palm is turned facing upwards, it's known as supination. When the palm is turned to face downward, that movement is known as pronation.